The state of healthcare in America is, well, complicated, to say the least. Access to care, quality of care, insurance, co-pays, bills. These are all just a few of the variables that define the state of our system and discourage patients. Now let's tangle this web even further. What's the state of healthcare like for women specifically? For some women, the doctor's office or hospital room is a place of care, compassion, and hope. For others, not so much. Disparities exist. Why does the healthcare system, especially when it comes to women, vary so wildly? There's clearly something going on, something not functioning in the system when it comes to female-specific healthcare. And our two experts today are working tirelessly to identify those shortcomings and solve the issues facing medical care for women. I'm Franny Lazarus, and you're listening to Now at Ohio State. We talk with researchers, innovators, and bold thinkers who look at our world, see what the real challenges are, and create the solutions that people need now. Now let's be clear. When we talk about healthcare for women, we are not just talking about going to your general practitioner because you have the flu or a cold. We're talking about disparity in care that ranges all the way to certain cancers. That's a big deal, and Dr. Ashley Felix has made it her mission to address this major issue. Dr. Felix is an associate professor of epidemiology in the College of Public Health at The Ohio State University. Her research focuses include cancer epidemiology, women's health, and screening and early detection. And all of this comes together in her work studying clinically aggressive endometrial tumors in women. She recently sat down with me to talk about the state of women's health, the importance of improving access to cancer care, and what needs to change to make the healthcare system work better for women. Ashley, thank you so much for being here today.
Thank you for having me.
Could you start with just introducing yourself to our audience?
Sure. My name is Ashley Felix, and I am an associate professor in the College of Public Health here at Ohio State University. I am a cancer epidemiologist, and I specifically focus on racial disparities that occur for women who have gynecologic cancers.
For people who aren't familiar, what kind of cancer is that?
So when I refer to gynecologic cancers, this refers to organs of the female reproductive tract. So we're specifically thinking about uterine cancer, ovarian cancer, and cervical cancer, among a few others. I will say that primarily my work focuses on uterine cancer, which is also called endometrial cancer.
Oh, I didn't know those were the same thing.
Yeah, so it's interesting. Endometrial cancer is actually like 90% of uterine cancers. It's termed endometrial cancer because it occurs in the lining of the uterus.
Sure. Your work focuses, as I understand it, on populations instead of individuals. What interests you about that?
So we know that the medical model is very important. Inevitably, people will develop diseases, and we need to be able to go see clinicians to help us with those problems. But in public health, we focus on prevention among large groups of people. And so instead of thinking about treating diseases, we really want to try to prevent those diseases from occurring in the first place. As an epidemiologist, one of the things that I do is I really try to understand associations or causes of different diseases. So we try to link different risk factors with diseases so that we can either remove those bad risk factors or, try to augment some protective factor that we find in populations. I think that it takes complex methods to be able to do this well. It takes people wanting to participate in your research. And I think that can be challenging. It's another thing that we ask people to do in terms of filling in surveys or doing something else for our research studies. And so it can be quite challenging to tease apart really what's going on in terms of what's associated with certain cancers.
Can you tell me a little bit about endometrial cancer? Why was it interesting to you?
When I was trying to hit upon a dissertation topic, I remember reading a lot about the fact that uterine cancer has increasing incidence and increasing mortality. And that's really different from a lot of cancers that affect women, but also that affect people generally. Most cancers, I won't say all, but most cancers are declining in terms of the number of new cases and the number of deaths that they are responsible for. But uterine cancer is not like that. It's increasing. And so, I guess this is about 20 years ago, but I think we were starting to see the beginning of this continued increase in this cancer. And the other thing that's really interesting and unfortunate about endometrial cancer is that these patterns of increasing incidence and increasing mortality, those increases are worse for women of color. So, we're seeing increases among all women, but when you look at rates among Hispanic, Asian, and Black women, they're much steeper than what's going on for white women.
Can you offer a guess as to why that would be?
I think it's a really important area of research currently, and people are really, this is the question that we're asking. Some hypotheses are that, obesity is increasing, and that is certainly true in this country, and obesity is a very strong risk factor for developing endometrial cancer, but that doesn't seem to be the only story. So what we've mostly studied, it's been reproductive factors, and so things like, do women take oral contraceptives? Have they used intrauterine devices? So those two factors specifically are protective, so they're associated with a lower risk of developing endometrial cancer.
Okay.
Other things like parity or the number of children that women have, actually just even having a birth is protective against endometrial cancer. Things like physical activity are also independently associated with lower risk of developing endometrial cancer. In line with obesity, though, there are other metabolic conditions like diabetes, as well as hypertension that are associated with increased risk of developing endometrial cancer.
So it's not always then just genetic bad luck if you find yourself diagnosed with cancer.
We think about like the web of risk factors. Maybe you're at high familial risk of developing something, but maybe your risk factors are low. Whereas on the other end of the spectrum, maybe you don't have cancer in your family, but if you have multiple risk factors for cancer, your risk actually might be quite high.
What are some of the symptoms of endometrial cancer?
Yeah, so the major symptom of endometrial cancer is postmenopausal bleeding. And so, when women have hit menopause, usually they're not bleeding any longer. And so, any signs of bleeding would be a signal that something is possibly wrong. But bleeding in itself is not a very specific symptom, right? And so I've read that, women in qualitative studies, women will describe that, they had bleeding, they saw their gynecologist, but then they didn't follow up. And so it was left there. But postmenopausal bleeding should really be followed up with a biopsy, particularly when women have multiple risk factors. So, it's one thing if women have bleeding, but if they also happen to be obese or have diabetes or have polycystic ovarian syndrome, which is another risk factor for endometrial cancer, these are the things that would alert a clinician to take the evaluation further.
So does that mean that it's mostly older women who are experiencing endometrial cancer?
For the most part, it is older women, but there is a small proportion of women who will develop endometrial cancer before they're postmenopausal. And it does become a lot more challenging to recognize the symptom of bleeding, and that might be related to something that shouldn't be happening because, again, if you're premenopausal, you probably have a menstrual cycle, whether or not it's regular or not. Other symptoms that are important are abdominal pain as well as back pain. But again, I think that these are hard.
That's a regular period.
Right, exactly. And so I think that becomes challenging for sure. And so, I think when you have regular visits with your doctor, just even mentioning these things, I think will help prompt further evaluation. And so I do think that this is why it's so important to have your yearly checkup and to really be chatting with your provider about just what's happening. And so a lot of women will have that initial bleeding and not really be sure, is this normal? Is it not normal? They may or may not see a doctor, but then maybe it'll be another few months before they actually reach out again. And by that time, we have some time elapsing, and that is not always the most conducive for an early stage cancer diagnosis.
You've said before that often it's the more severe cases that are being diagnosed later, and they tend to impact minoritized women. Why are they being diagnosed later?
There is definitely empirical evidence that suggests that women of color, particularly Black women, are diagnosed at later stages. So disease stage really, the earlier that you can catch a cancer, the better. As stage gets higher, that means that the cancer has disseminated. One of the things that I've read recently is about silence around symptoms. And so I think when you talk to Black women about why they didn't go see a doctor sooner, right? Because they had some of those heralding symptoms that are sort of odd that would, usually cause someone to go see a clinician. And, they recognize that they had these symptoms, but I think that there are certain barriers that prohibit women and minoritized women in particular from seeking care. It's definitely harder to treat those cancers regardless of a woman's race, but we are seeing that even among those later stage cancers that for whatever reason, women of color aren't receiving the appropriate care. That's part of the research I'm working on now, is really trying to understand why this is happening. When we have good evidence about the kinds of treatments that work, I will say they don't work always, but the treatments that women really should be getting, they're not always getting them. And that's pretty puzzling to us, why that's happening.
What can patients do then to advocate for themselves? Is it having a better understanding of what to look out for? Is it following up more aggressively with a provider? What would you recommend?
I do think the latter, right? I think following up more is really good, because I would hate to put the onus on individual patients that they need to know exactly what's going on with their bodies. But I think that women specifically, we do know our bodies well. And I think that we know when things seem off. And I think that even if somebody else doesn't immediately, take it seriously, I think that we should continue to follow up and try to get answers. We might not know exactly what we should be advocating for, but I think that consistently raising that you have an issue and that you really want to be seen for it, I think that that's the important part.
For women who are either they live far from their provider, they are a single parent, they're juggling multiple responsibilities, is that in and of itself then a barrier to care if they have to go back for a second appointment, go back for a third appointment?
It certainly is. I mean, I think that these are sort of the larger structural issues that exist. And so if people lack transportation, having Ubers available to help, patients get to their appointments, I think that that's important. I've seen some innovative things related to childcare. That's something that they consider in terms of trying to help people get to their appointments. And so I think we have to be a little bit more creative about the solutions. It's not just, we found the best chemotherapy for these patients. It's how do you get people to continue to come when you need to come, 3 days a week and sit for an hour for an infusion? That's time. And we really need to make sure that we're thinking about what other things people need to be focusing on.
Ashley, thank you for coming and sharing your expertise with us. This has been really interesting.
Thank you for having me. I had a lot of fun.
These healthcare disparities aren't limited to cancer treatment. They're also not limited to our country. They're worldwide. And it's not just about access to care either. We are dealing with deep-seated systemic issues of bias and inequity that are adversely affecting women's healthcare. Dr. Shamika Poetry Thomas knows this all too well. Dr. Thomas is an instructor in the Division of Bioethics in the College of Medicine and a provost fellow in the Division of Bioethics at The Ohio State University. She is a global maternal and child health scholar focusing on sickle cell disease and its impact on Black women in the United States and in Ghana. Next, Dr. Thomas talks with me about her own healthcare equity initiative, the challenges women face in healthcare, and how advocacy can lead to better outcomes. Dr. Thomas, thank you for joining me today.
Thank you too.
Your background is in bioethics, is that right?
Yes.
What does a bioethicist study?
Coming into maternal and child health, science from a bioethical standpoint relates more so to the ethical, legal, and social implications of what it means to be on the reproductive health spectrum. So I work with female adolescents who are dealing with menstruation health, things like blood disorders or delayed menstruation. Also, young adult women who are dealing with fertility issues as they navigate having a chronic condition or genetic conditions. And then also have worked with older women who are dealing with pre-menopause or postmenopausal stress as it relates to their conditions with child labor and postpartum or maternal pregnancy loss, postpartum depression. So it's a full spectrum along the life course,
Wow.
I would say. And it's mostly from a bioethical sense of how women come to negotiate their decision-making processes, how they interact with clinicians, how they interact with treatment, how they resist treatment. Maybe they are hesitant to certain treatments. Maybe they have developed some type of traumas that might inform how they see gynecologists or obstetrics. So bioethicists are in a very unique position to be able to ask critical questions of the field and be able to have conversations with many different types of scientists across the board. And then we're able to help respond or understand the lived experience of the total patient, intersecting with social and clinical perspectives.
What led you to studying bioethics? Was there something about it that you find really compelling?
Reproductive justice led me here. I definitely have a heartbeat for doing what's right and actually seeing and hearing patient stories. I feel like I'm the bridge. I'm able to travel between worlds, travel between disciplines, travel between countries and cities, if you will, and be able to kind of package and framework the research in such a way that each audience is able to kind of take off sound bites and develop it as they go along. So I feel very, very blessed to do what I do and to bring this work to the field.
Your research focuses on the intersection of sickle cell disease and women's reproductive health.
Yes.
How does this approach benefit patients?
Patients do not come to clinical encounters with separate, experiences.
Sure.
They come as their total selves. They bring all of who they are to patients. They don't leave their race at the door, their gender at the door, their sexuality at the door, their disease at the door. And unfortunately, when we are going into these academic spaces to study our work, we're studying it in silo. Hematologists study hematology, OBGYNs study reproductive conditions. And oftentimes the two are not always in deep conversation with each other. Maybe they are in conversation, but I believe it needs to be deeper and wider.
Okay.
Because patients are experiencing these things simultaneously. And so now we need to understand the critical ethical implications of what it means to navigate a chronic condition and still, want to preserve your fertility, or still want to have children or not have children, or still just want to understand more about your reproductive capacity, your menstruation health, understand fibroids, understand ulcers, understand anything that's impacting your reproductive area and space. So we need to be able to have conversations on a much more granular level as to how reproductive health impacts patients. And when patients come to these clinical encounters, how are they showing up? And how can we prepare ourselves better to respond to how they show up?
Let's take a step back, if we could, and talk about sickle cell on its own. What is sickle cell disease?
So sickle cell disease is a chronic condition. It is a genetic condition where in order to have the actual disease, you need a trait from your mother and a trait from your father. And when you have sickle cell, it impacts the entire body. So, for example, typical red blood cell is circular shape, but with the sickle, it's shaped like a C or a crescent moon.
Oh, okay.
It's sickled, right?
Got it.
And so those sickled cells clump together and they clog up the blood valve so that the blood can't pass through. And it's very, very painful.
That sounds painful.
Yes. I've even had one patient describe to me that sickle cell pain is even worse than labor pain.
What are some of the impacts that sickle cell can have on a person who's pregnant, person who's menstruating?
So typically when a female adolescent, and she has sickle cell disease, she would typically have a delayed menstruation. So most preteens receive their menstruation or menses as early as 9, 10, 11, 12. I've had female patients who haven't received their menses and they're 17, 18 years old. When it comes to things like pregnancy, the pregnancy can be terminal. It can also be something like pregnancy loss. It can also lead to having much more like preterm labor.
Really?
Yeah.
Okay.
Some of the women also have to undergo like blood transfusions during, having to negotiate what that looks like.
Right.
Not being able to take certain medications, not being able to take certain birth controls because it impacts the treatment. So it's so much that conflicts with what it means to kind of have like your reproductive health on the line while navigating a condition. Another issue is fertility preservation.
Okay.
Now that more patients are being a part of clinical trials to screen for sickle cell disease and things like that, or alleviate it, so to speak, now patients have to decide, do I alleviate my sickle cell, disease completely, or do I keep my reproductive capacity?
Wow.
And it's almost like deciding between the two.
Wow.
And then there's the racial component that goes into there. So it's also like Black women in particular having to decide,
right?
Do I not have kids, or do I preserve my embryos? Do I, how do I navigate this space? And there's not a lot of scientists who understand what the fertility aspect does to a patient with a chronic condition like sickle cell disease.
Tell me about your research in Ghana.
Sickle cell disease is very prevalent there, which in the sub-Saharan Africa area, about 1 in 3 Ghanaians have some type of sickle cell or a genotype disorder or a sickle cell trait. And so this research really was instrumental in going there. And when I was there on the ground, I noticed that the intersection between understanding sickle cell disease and maternal and child health is very far apart. And so to kind of understand how we can close this gap between what women are experiencing when it comes to sickle cell and how they're navigating reproductive health, we can do so much more to kind of bring in some more patient knowledge to the clinical space, as well as giving patients more of a space to kind of let them know that they're not alone on these issues. So, yes, I founded and created a program or a project there called SWAG. SWAG stands for Sickle Cell Women and Girls. And we have about 45 patients that we've kind of followed throughout our journey. And those patients range between 13 years old and 25 years old. And a few of them are also young moms.
Oh, wow.
Yes, young moms navigating sickle cell disease on the ground. So it is such a it's delicate project, and it's very, very heartfelt. But I've learned so much from these amazing women who live their lives with such audacity. Yes.
SWAG. I'm guessing that in addition to what it stands for, you chose that word for a particular reason. Is that right?
Yes, I did. So I was sitting in my office, and with these research grants, pages and pages, almost 100 pages of IRB and grant proposals. Right. So you need an acronym. And I knew that I wanted an acronym that will not just be something that scientists understood, but something that patients could feel drawn to. Okay. That can give some type of, you say, feminine power. Okay. Some type of, spice. And so the word swag, I come from the Black community. I'm African American. And swag just means you have extra confidence. You have this sauce, this power, this swag, this style about you. Right. And so I decided to just pair it with the lived experience, or understanding the lived experience of a genetic condition. Because these patients are not, just tied to their disease. They are living their lives. And that is swag. That is, you're living with something, and you're making your own way throughout your world. Wow. You're not defined by your condition. You actually are an amazing woman who is beyond your condition.
So you've invited patients to help analyze some of the data that you're collecting.
Yes.
Why did you do that?
This is something that I believe is attributed mostly to methodological justice or methodological equity. In order to give back to the research process would be to invite the patient in to review some of the data, review some of the transcripts, and ask them, did we capture your story correctly? Can you tell us what we did right, what we did wrong? Can you review these patient files and let us know what this means for you? How should we name this and frame this for you? One of the reasons why I invited some of the patients to review these files is also to show that research is a collective process. Okay. I can't do this without you. And we need each other. We are working together. I'm not doing research on you. I'm doing research with you.
That's an important distinction. Dr. Thomas, thank you so much. This has been enlightening and moving.
Thank you. It's definitely been moving. It's It's made my day.
Hope will bring me back to life. With a change of scene, I hear my future calling.
It's abundantly clear that there are changes to be made in doctors' offices and hospitals across the country and around the world. But the important work of advocates like Dr. Thomas and Dr. Felix is helping to pave the way for a more equitable, more compassionate healthcare system, one that truly listens to and serves all women. Because when women have access to better care, we can live our lives to the healthiest and to the fullest. Now at Ohio State is produced by The Ohio State University's Office of Marketing and Communications. For more information, visit us at go.osu.edu/now. I'm your host, Franny Lazarus. Thanks for listening.